one and all gathered here. It's my pleasure to introduce our esteemed speaker for today's event, Dr. Nikita Mehta, a highly accomplished and dedicated academic in the field of homeopathy. Dr. Nikita Mehta serves as an assistant professor in the Department of Paediatrics at the prestigious Dr. Dhawale Memorial Homeopathic Institute, Palghar, bringing with them over 5 years of teaching experience in this role. Dr. Mehta previously served as assistant professor in the Department of Community Medicine at Nobel Homeopathic College, Gujarat for 2 years, showcasing her versatility and dedication to advancing homeopathic education. With a passion for curriculum development, Dr. Mehta is a subject expert in pediatrics for the postgraduate competency-based dynamic curriculum under the Homeopathic Education Board, National Commission for Homeopathy, New Delhi. Their contribution to shaping the future of homeopathy are remarkable. Additionally, Dr. Mehta is a recognized postgraduate guide and examiner in the homeopathic pediatrics at the Maharashtra University of Health Sciences, Nasik, mentoring and evaluating future leaders in the field. They have also enriched countless learners as a resource faculty for standardized case record training, faculty development programs, and the esteemed principles and practice of homeopathy course at MLD MHI. Dr. Nikita Mehta holds an MD in homeopathic pediatrics completed in 2009 and is currently pursuing PhD in homeopathic pediatrics at MUHS under the esteemed guidance of Dr. Chandrasekhar Gowda at Dr. M.L. Dhawale Memorial Homeopathic Institute, Palghar. With over 15 years of clinical experience, Dr. serves as a homeopathic consultant in pediatric inpatient department, NICU, and homeopathic pediatrics and adolescent OPD, showcasing their commitment to providing specialized care to children and adolescents. Dr. Mehta is a prolific researcher and a valuable contributor to the homeopathic literature. She served as a reviewer on the board of esteemed journals such as the Journal of Integrated Standardized Homeopathy and Homeopathic Links, in addition to the publishing articles regularly in the National Journal of Homeopathy and Journal of Integrated Standardized Homeopathy. Please join me in extending a warm welcome to Dr. Mehta, whose dedication, expertise and contribution continue to elevate the field of homeopathic medicine. I request Dr. Jyotsna Shivaprasad, Professor, Head of the Department of Paediatrics, to welcome Dr. Mehta with a floral bouquet.
Become a researcher, become an academician, and apply children cannot even speak, we can show that homeopathy is not a placebo at all. Because we have really beautiful results in neonate as well. So our whole curriculum can be really path-breaking if we really follow what EPAs actually are. So EPAs are the entrustable professional activities. We had a good demonstration by Muller sir in the morning. I'll just try to again go through it. So it is an activity, a work, a task which the resident should do, the MD resident should do, so that they can be fully entrusted. And once they demonstrate that necessary competence, they can do that activity unsupervised. For example, we have these OPDs running, and when we are for example, right now I'm out of the OPD and my students are there in my OPD right now. So they give me a call that so and so patient has come, and what remedy should I give? So then sitting here at Mangalore, my resident should be entrusted by me enough that he is able to give justice to that patient properly, take a proper history, do the examination, come to the diagnosis, come to the totality, whether it is an acute disease, chronic disease, understand what remedy can be given, what postology can be given. So these are actually the professional activities which we do day in and day out. And I am right now at the remote supervision. So my student should be at level 4, right? From novice to advanced to competent to proficient. Proficient enough to take a totality of a patient, give me a call, and then he becomes my eyes, where I'm seeing the patient through that resident. So I should make my resident capable enough so that this can be brought into practice, where we are just facilitating how they understand the case. Right? Am I sensible? Am I making sense? So EPAs are what professionals do in practice. They should be observable, measurable within the time frame, and suitable for entrustment decision. If I trust that they are proficient enough, I trust them. There is no, either it is a yes or it is a no. Whether they are entrusted or they are pre-entrusted. Why did I take this example is that driving a car, right? So when you achieve the level 4, the 5 levels which are there of the milestones, when you achieve the level 4, you are proficient, so you get the license. License to drive a car or license to practice. It is very easy to correlate it with driving a car. You are given the license only if you drive it properly at all times. You cannot say, oh, I did the accident today only, otherwise I am very good driver. So you are given a license to practice. or an emergency, we don't know yet. So let's explore how we should go ahead with that. So history will mean that we will have to be taking the clinical history as well as the homeopathic history. That will happen simultaneously, right? So the stools, the number of stools, what is the consistency of stool is asked by any pediatrician. But a homeopathic pediatrician will ask whether it is offensive or not. Going ahead from offensive, we will ask what type of smell it is, because we have rubrics like that. We have cadaver-like smell from the stools, we have sour-smelling stools, and the remedy changes. Sour-smelling stools, rheum is there, melose is there. Cadaveric, offensive, arsenic, protonic, right? So, right from the level 1, when you are collecting the history, you cannot do that I will take the clinical history first and then go to the homeopathic history. No, there's no need of doing that. You can do it simultaneously, right? So that kind of a knowledge, if the resident has, they will do it at the bedside. So that is how, if you know what are the types of stools, there's a Bell's diarrhea repertory which is there, dedicated specifically to diarrhea. If you know the construction of Bell's diarrhea, then you can, take the whole case of a diarrhea based on Bell's diarrhea, and you will crack the remedy within 10 minutes if you have that habit of doing that, right? So the history will involve evolution, cause, and the associated symptoms, right? We have elements from also, whether it was from spoiled milk, whether it was from some watermelon, some fruits. Evolution, of course, the ODP, what came first, what later. Associated symptom, whether there is a vomiting, fever, abdominal pain, because our diagnosis will change and so will our understanding of homeopathic gathering of the case, right? Examination, general examination, vitals, GI examination, dehydration, very, very important in infants, because the level of dehydration will again depend how will you manage. Level 1 dehydration, ORS will be enough. Level 2, level 3, we will have to admit and give IV fluids. And CNS, because of dehydration. If there is severe dehydration, the child might become comatose, go into ARF. Now the differential diagnosis, how does a student from clinical history and examination go to the differential diagnosis? That will again depend on age, right? For example, if it is an infant who is just 9 months, it can be because of dentition as well. So dentition becomes the cause, as well as a dentitional diarrhea is very common. The child has habit of picking anything from the floor and eating. Or there can be food poisoning after the child has been given something from the street. Or it can be simple viral diarrhea because of the rotavirus. Or it can be a maxillary dysentery. Right? So this is how from the evolution the student will start learning how should I apply these knowledges together when I am handling a child. Investigations, CBC, CRP. Diagnosis should be with reasoning and criteria scales. So now in a case of diarrhea, scales like the levels of dehydration is a scale. So they should know that I can apply a scale here. Common versus characteristic symptoms, again very important for homeopath. Common symptoms will help us to know the diagnosis. Out of that, what remains uncommon will be our totality. And of course the next steps like H&M differentiation after the referrization in the first EPA, it is like treating a whole case. So everything will be involved. You need to have knowledge and scholarship. Remember the case of diarrhea, right? You should know the knowledge of patient care. You should know homeopathic orientation. You should have communication skills because mother will give the history. You should know, now mothers are very anxious. They are crying in the IPD. So you have to calm her down and take the history. Mother will say कि अरे मेरे बच्चे को stool हो रहा है and you are asking for the smell of the stool. Are you mad? So you have to, you have to be calm first, right? To make the anxious mother calm, right? So communication skill, practice-based learning. At the end, we are all doing that. And professionalism, of course, the ethical codes and the medical legal parts of it. And if we see the EPA 8, the one of oral presentation, then we see that basically homeopathic orientation and practice-based learning are not that much part of it. When you make an oral presentation, of course, you need to understand the homeopathic orientation. But at the level of EPA, it is an integrated approach, so it is not very, very highly understood in that way, right? So let's see the tables. So we can open HOM PGPED 09 so that we can relate this case again to that topic. So that is clinical approach to alterations in gastrointestinal functions and its integration with homeopathic management. Yeah. So again we can take the same case, increased frequency of stools. It is a gastrointestinal function which has been altered. Usually the infant should have one or two stools per day, but now it has gone to maybe 10 and 15. Right? So is it visible? I've just taken it from the. So now you see, discuss the clinical approach to a child with increased frequency of stools, right? Enumerate the causes that lead to the development of the symptom. We discussed everything, right? Dentition, milk, various viral causes, bacterial causes, right? List the possible complications. We did that. And discuss the homeopathic management strategy. We did that as well. So if you have these knowledges, then you can have that competency of understanding the alteration in gastrointestinal function. Once you get that competency, EPA 1, part of EPA 1 gets covered with this course, this topic. So there is a to and fro journey from EPA to a topic and from topic to a EPA. Right? This topic will have another EPAs also. Right? And another EPAs will be covered by this topic as well. But right now, can you correlate EPA 1 with this topic? Yeah. Skill, perform simultaneous clinical and homeopathic history for assessment and arrive at differential diagnosis. We just did that. Something back. Perform the clinical examination of GIT and other systems. For understanding dehydration, there are various examinations. You have to see the tissue turgor, you have to see the capillary refill time, you have to see whether the eyes have sunken, how is the anterior fontanelle. That will help you to understand how much is the dehydration. So all these skills are also needed, right? Choose appropriate investigation and arrive at the range of diagnosis. Identify common stool for reducing substances. It is an investigation to understand whether there is lactose intolerance or not. There can be children with primary lactose intolerance and secondary lactose intolerance. So if I know that stools for reducing substance can be ordered, then I will be able to understand how this child is landing up into diarrhea. Right? That will be usually a chronic diarrhea. So choose appropriate investigation, identify common and characteristic symptoms, repertorization, basic management strategy. The reflection is then the lecture or in the cases, right? So case-based learning, bedside learning, ward rounds, outpatient-based, spaced repetition, deliberate practice, reflective learning, self-directed learning, simulations. Anything can be used. If you can connect it with the case, for example, bedside learning. I can show the resident how you should know the level of dehydration by demonstrating the examination findings. Spaced repetition is something very similar to memory-based learning because it is said that in PG the rote learning should not be done. You should not memorize, you should learn the concepts. But when memory-based learning is done smartly, it does help in making the new neurons and it goes into your long-term memory. For example, levels of dehydration. Some amount of memory-based learning will be needed because otherwise I'll get confused that in grade 3 dehydration there is comatose or in, so some amount of memory-based learning is this spaced repetition. So when you repeat the thing deliberately again and again, it goes from your short-term memory to your long-term memory. Right? You remember how that repetition recall, how long-term memory improves. So right now after 15 years of experience, I can tell you the grades of dehydration in a minute. But I required some type of spaced repetition. Every 6 months I have to read once. अच्छा हाँ यही है ना levels of dehydration, कुछ गलती तो नहीं हो रही है. So every time I teach a lecture of dehydration, I go through it once. So that is spaced repetition. Deliberate practice is keeping on practicing again and again till you master a skill. Usually it is for a procedure. For example, if I have to put an IV for giving the IV fluid to a child of dehydration, I have to keep on practicing, finding a vein, inserting the IV line. Right? Rest all I think are easy to understand methods. And for assessment, we'll be having 2 formative assessment and 1 summative assessment. In that, we can put this as a case-based question. Again, go to the example of increased frequency stool. How will you make a question out of this kind of a case? That can be done for the theory exam, informative as well as summative. That will become a case-based question. Okay? And for assessment at the bedside, we can have OSCE, DOPS, mini CEX. For example, now I have to simulate. I have to make a OSCE station. Then I will keep one station of what are the causes of diarrhea. Next station can be what are the levels of dehydration. There will be a patient and I will ask the student take a history of diarrhea. Right? So this way I can prepare a OSCE station or do a direct observable procedure thing also. I will see how they are taking the history. So when we have a long case and short case, right? We take a case of diarrhea and can see directly how the student is performing. There are a list of texts which can be seen from where diarrhea can be learned. So any textbook of Paediatrics, our Homoeopathic book, Bell's diarrhea are all listed in the list. And this particular course, this one, is dealing with all these 4 competencies. Okay? And this is the topic content under gastrointestinal function. See, there can be more functions, but these are just representative. Right? It is not watertight. There can be symptoms, but this is just a gist of how you should go about it. Right? Refusal to feed, vomiting, diarrhea, constipation, weight loss, GI bleeding, jaundice, abdominal pain, abdominal swelling and ascites. So in the morning we understood that there are 2 kinds of learning methods, teaching learning methods. Any questions so far? Is it too much? No? Is this space okay? majorly cover. So you can apply the same to the other topics, other EPAs, and like Munir sir said, I am also studying it since last 2 years because we are working on this document since 2 years. We have gone through a lot of articles which are given in medical teachers, the journals of medical teachers. And unless you sit and do it for yourself, it is very difficult to understand what EPA, what competency, all you got to watch. So, by far we have covered the basic areas of curriculum. Go through it once again, go through the terminologies, try to attend webinars on EPA, then it becomes a little easier to understand. Otherwise, these are, actually we are doing this. This is a old wine in a new bottle. So that bottle has to be understood. The wine is still tasting good. Okay. Yeah. Yeah. Yeah, we can go through that. So, see, actually, these are not complete. You just try to list down. You can apply any method. So, for role playing, you will have to make one a student, make one a mother, where the mother is crying. Let the student explore how to make history from a crying child. You can make one 4-year-old boy and how a 4-year boy will. So, there usually in role play there are 3 people: student, the patient, the physician, and the attendant. So that here we can do it very well. This is just for putting an example so that your thinking will start. For any case taking, you will need all the 3 domains: knowledge, skill, and affective. And especially for pediatrics, we need a lot of affective domain is very important. Yes, it's an old wine and a new bottle. We have been doing it. New terminologies have been given. And now, see, earlier what we used to do was we used to have a syllabus and we used to complete it. Whether the student is understanding or not, whether the student has become competent or not. We were bothered, but we were more bothered of completing the curriculum, which is never possible for pediatrics. In my last 5 years, I have never been able to complete pediatrics in 3 years. It is not possible. It is not humanly possible to teach everything. But if I teach a EPA, for example, how to manage a case of diarrhea in your clinic. Suppose if I aspire to make them a competent pediatrician, my whole assessment and my whole teaching method will change. Because now I have to make sure that they are able to take a history. I will not keep on talking about have I taught all the types of diarrhea, have I taught all the types of diarrhea. Then they will have to self-learn. Exactly. So that is self-directed learning. But here and then that their flipped classroom will be very important. Suppose you announce 1 week back that we will be dealing with a case of diarrhea and you circulate one case. Give them 1 week. If they are going to work on the case, जाके पढ़ के पढ़ना पड़ेगा. They cannot move ahead only. Suppose I give this much. That you have a 9-month-old infant coming to you. The mother is saying this. Give some list of symptoms, 2-3 examination, and ask them what history is not been asked. What examination is missed. Give a deficient case. Then they bring each semester your competence level will go on increasing. You are getting the. So what we can do is that for each EPA, for the first semester, we can understand what is the level. And then for semester 1, we can program our whole curriculum like that. Yes. 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 In the next year. And for example, see now if I have taught them that this is how you should collect the history for diarrhea. Now it is their job to learn it for cough as well. Because the template will remain the same. What are the causes of cough? How to take the evolution of cough. So let's go to the diarrhea case. Now replace this with cough. They will have to read this also. So if you have already taught them how to take an acute totality in a case of acute gastroenteritis, and you have given them the concepts, that is why we are dealing with concepts and not the contents. Right? So if I have made them read it like this, they should know how to apply the same template for cough. So in suppose in semester 1 we took it for diarrhea. In semester 2, take to the next level of cough. Then in the next semester, they have to do it. This is the self. See, look at the courses. Part 1 and part 2. Yeah. Because you are not bothered with how content is being spectacular. You should train them how to become a good clinician. That is why the outcome which we are looking that is why if I know the logic of treating a case of diarrhea, if I apply my inductive and deductive logic, I will be able to apply it for cough. I need not teach cough. Yeah. So you test them. Now that will change, no sir? Inspection guidelines will change. Don't worry. Because you cannot humanly cover the whole syllabus with EPA. It is impossible. The inspection rules will also change. Don't worry about the paperwork. You just now worry about that whether my student is able to practice homeopathy. They should not become mad.
Now the problem is, let me tell you, for the last 15 years we all of are having a syllabus with us. And we start with a particular syllabus or a particular when the student comes. And that 1.5 year syllabus we are ready with that.
Correct.
That syllabus in some colleges start with some embryology,
Correct.
some colleges start with growth and development, like that it goes on.
Correct.
So from this methodology, how we will do that? What we should do on Monday afternoon, morning we are in clinics.
Correct.
I hope all of you are like that.
Yes, yes, sir.
Tuesday what we should do?
So sir,
On Wednesday what we should
just
do?
open the EPA table.
Ah.
One I show you.
Ah.
Just open the EPA
Yeah, yeah.
table. In that, for semester 1,
Yeah.
there are levels. Yeah. Just open the mapping of EPAs.
Okay, that's
The
understood.
table where
How to implement that is all.
I'll give you an example. Unless you open it, I will not be able to give it.
You tell ma'am.
Page number? Yeah, this one. No, this one. Page number column. There are various levels for each EPA. Yeah? Now you go through the topics. And which topic will help you to deliver which EPA to this level is how you will plan your Monday. Are you getting my point? Correct. That is first. and there is an engine failure of all the 4 engines. Okay? And in the end, there are 300 lives on the board, on the plane, and he lands, and there are 3 airports in the vicinity. You have seen the movie? There are 3 airports in the vicinity of that plane, but he decides that I will land my plane in the river because all 3 are far enough. He lands the plane in the river, Hudson River, and he saves all the 300 people, and a committee is made where they make simulations, and they find out that yes, it was not possible to land at any airport. He would have landed into the city. So it was the right decision to land the plane into the river. Now to do that, what skills, what control of emotions, what coordination, what presence of mind, what knowledge you want. This is a real-time practice, no? You are driving a plane. This is a real-time scenario. You cannot say that I landed up into the city. No, you have to foresee it. That is why entrustment is prospective. You learn that way, no? Entrustment is prospective. I should entrust my student that he will take the fever history properly, which many of them don't do, even at final year. Ma'am, it has to be 100. That is the whole point. For research also there are 3 EPA for research. The department has to take care of that. This is not everything. That is why I said you have to do what is that pro journey. This is not EPA. You have to write it down. That EPA is covered by all the students. And teach only that much. See, anyways, are you covering the syllabus? In pediatrics, I have never been able to cover the whole syllabus. It is
And
humanly
we are
impossible.
not able to cover the syllabus, but we
So
have a
this
syllabus.
also-
We have a syllabus.
We have to cover
Sir,
5
but are you happy when you see that your class of say 50 pediatric students are 45 of them are practicing allopathy? Are you happy? Then what's the use of teaching the whole syllabus?
And that's
Then
not the
they are
issue here.
very very proficient children, sir. I won't get dust.
And that's not the issue here. The teachers want to know how to implement the syllabus practically. Every day. Every day. That's what we want to know.
So don't go like that. That is why please, if you will go through, please go through articles of EPA. It is not about going system-wise. Please don't go system-wise. Go EPA-wise.
Then in what way we have to do? In what manner we have to go? How to enter into the pediatrics? Just tell one example. For a new student, tomorrow I am going to give a syllabus. How to start?
So I will take EPA 1,
Okay.
right? From now let us all do this activity together, right? Let us all do this activity together. Open all the topics and tell me where EPA 1 is applicable. You have to see all the topics of every partner, semester 1, and tell me EPA 1 is covered by which topic? Which topic you will teach in semester 1 to cover
worked out. And entirely we are going to change from November onwards to another methodology which you are telling without a lesson
I'm
plan.
telling you, I'm still not teaching all the topics.
That I don't know. I am telling you what we are
I'm
doing.
telling you.
I cannot complete all Paediatrics. Of course, that we agree with you. But we are having a syllabus. But we are having a syllabus.
The book has to be finished.
Now you have the EPS, don't worry.
Shouldn't we ask?
The whole inspection.
That's right.
Whole inspection will also change.
We are still having the concept.
Please start from a clean slate. Do not compare the past with the present. Otherwise, you will fall into a pit.
What will be the assessment for the child? I am the student, KG student for exam.
Can I come to that because you are going to allow us finish my question?
Yes, please.
You complete it. You complete it.
So you all know the peer-based and the individual-based learnings, right? Or should I go into the details? You all know this?
It's all okay.
Let's go to the assessments then. Yeah. So how many of you are aware of Muller's pyramid, Bloom's taxonomy and Gilbert's levels? All of you? Basic HSCT.
Recently understood.
Basic HSCT done, no? So Muller's pyramid has knows how, shows how and does. So knows and knows how is knowledge. Shows how and does is performance. Right? So if you are testing the knowledge, right, and you want to know the know and know how, from the topic, make an application-based question or a long answer question or a short answer question or an oral examination and test their knowledge. In the theory, right, because there is no shows how. Correct? Agreed? If you are testing their performance and if you want to see whether they can show how can they do it or whether you want to see whether they are able to do it actually, then again the assessment tool will change. So for shows how, you have OSCE, where it is not real time. You have to create a mimic a real time situation like we just had an example. And simulation based. If you have a simulation lab in your college, then you can see how shows how. For does, you will have to either have a mini CEX where there is a real patient in your ward and the student is performing. You have a checklist. For example, if they did not introduce themselves that hello, I am Dr. Nikita, I will be examining you, do not do that checklist box. For example, I am testing the student to understand what is the level of dehydration. If he doesn't do the tissue turtle, don't do the checklist. This is how I will see whether they are able to do it. This is the last level of Muller's pyramid performance, where they do it in the real patient. For the affective domain, which sir was saying about role play, right? So in role play, there are assessment tools like checklist, again, greeting the patient. Did the student calm down the anxious mother? Was the student himself calm? You know, sometimes we get angry that make this crying child shut. You cannot do that. So that empathy has to be there. And rating scales, there are various rating scales for rating the student's affect. Those are the tools for affective. So this is how they will be assessed. So for all the domains, you will have different assessment tools in your formative and in your summative. Both. So theory will be majorly covered by all the four above, and the practical and the viva will be covered by all these. Portfolio is like your notebook, and rubrics is the complete overall assessment of the student. That you have to read whatever kind of assessment. These are the conventional tools which we can still use. The lectures, the assignments, clinical rotations, workshops. And these are the assessment methods which we can use with these conventional teaching tools. You can have a quiz, for example, if you don't want to teach cough, right? Keep a quiz competition, tell them make 4 teams, ask the questions on cough. The cough is done in 1 hour. Because it is self-directed learning. They have to, if they want to win, they will read cough in 1 hour. Our students do that because that winning and competitiveness, you have to instill that. Right? I had made a crossword to understand certain topics. And they all, I had kept a competition of crossword on breastfeeding. It was World Breastfeeding Week. I made a crossword for breastfeeding. I had 10 across and 10 below. And 20 marks crossword. And whoever was the highest, I told them I'd give you a chocolate or whatever. And they read breastfeeding very nicely from various articles, from textbooks, the techniques, the constituents of breast milk, what are the complications, what are the breast complications, what are the advantages, disadvantages. Why? Because they wanted to win that crossword competition. So I didn't teach breastfeeding at home. It was a matter of, and actually I did not sit also. I just gave the crossword. That too in Google Classroom. You all are aware of Google Classroom? It is a software that Google has. I just floated it and I said I closed there is a closings in that you can submit it up to some time only and you get a notification. So I closed it in 1 hour. Those who gave their submissions within 1 hour, it will assess also. Google Classroom will do everything. If you make a Google form, you don't have to correct also. If you feed the right MCQ answers, the Google will do it for you. Or what I do for the MCQs, I exchange the papers. So if you have written the MCQ, your people will go to your batchmate and they check very strictly than me because they don't want the other one to score more. So I did nothing. I just made the MCQs. That is the only hard work I put in. Rest everything either Google or they did. I had to make a mark sheet and my topic was done. So we'll have to come with innovation. Right? So I did not teach cough, I did not teach breastfeeding, everything was taken care by them. But then if they come for references, you have to search good breastfeeding and very less literature in the textbooks. So I gave them a few articles of NCBI, very beautiful articles. So that you have to provide. That we can do. This you all have seen, right? Formative is at first and second. Summative is doing the 18 month. This sir has taught in the month. Yeah. We'll now do the question paper view quickly. Now, suppose this is a question 1, right? 2, 3, 6 and 7 are to be covered by the long question. It is there in the book. So these are the topics. We are talking of the last, that is at the end of first year, after the 3 semesters, how will they come for the summative examination, theory exam. So these are the 4 topics for the first question, which is of 20 marks. Page number 41. 41. Yeah? Question the hang of it. Don't rush. Get the hang of it. That ma'am asked a question, did everybody get it? She is asking why only these 4 topics for question 1. Please go through it and you come up with the answer so that I can know how you are doing. You go through others and then you correlate. You go through the topics and yeah.
Tomorrow, NCA people will come and ask what you have done to the student. We have to answer. What they are going to ask, we do not know.
Sir, I think that let Jata's going to answer it. Because there also it got very heated up. There the teachers were worried about them, now we are worried about students.
Of course.
Yeah. So your administration will come up with it. So we have been following CBDC since years. I have a question which I have prepared for you. I want to see the example. But you all are not coming up, so I'll show my example. So I'm giving only question 1 example. I'm just giving a template example of one. Otherwise we'll need a multi workshop. So this is an example where I will be giving this history, right? The examination, the weight, the anthropometric measures, and then I can come up with these sub-questions. Give a case and prepare questions. Right? So evaluate the growth of the child based on the parameters given and reach to a proper clinical diagnosis of the case with its Honeymanian classification. And also have to be very specific, give very specific marks. It should not be a open-ended question where the student can write anything from definition of homeopathy to whatever they want. So I will give 2 marks only if they evaluate all the parameters. I will give 2 marks only if they reach the probable clinical diagnosis, and the further 2 marks if they give the correct Honeymanian classification for that case. Okay. Next is enumerate the factors affecting
after hours.
Take them to the community.
Every day.
So that you will have to plan how you can either take one full day in the community or 2 days after lunch in the community. Take a camp, just teach them how to say parents in school children.
So now we have
Take them to a school, take them to a orphanage.
we have to admit the cough case. So in the afternoon we have to go bedside and we have to discuss the cough over there. As a
You
theory,
can arrange a camp in your vicinity, in your hospital. You can advertise that every Saturday we will be having free camp. Let people come in.
You can have them anytime in the hospital, provided you should have patients.
along with the presentations.
They can have presentations and after also.
Case based, like
Case-based.
so the case, let's say presentation student will present the diet.
We had a lot of
We have two papers. Paper 1 and paper 2. They are talking about this paper. I'm asking what's to do with paper 2 now.
majority of people are not good. So a doctor was
No, that will come along with the homeopathic subject. Ma'am, there is an integrated subject. The paper 2 is there. Part 1, we have 3 papers. 1 is for pediatrics. 2 is for integrating pediatrics with homeopathy. Subjects. Fundamental. And third one is research. That's okay. Fine. What to do with paper 2? Whether these things are.
Vipin sir took a whole 1 hour session on that. Vipin sir's paper was that. Overview of it.
Fundamentals and properties we have to take